Welcome to Coffee with Kyle number 11. I'm Kyle Ridgway. Good morning to some, good afternoon to others. I had known her for 6 days. Every day I entered her room to see if she was awake, if she understood what I was saying, and if and how much she could move. I assisted her in lifting her arms and legs, sitting up at the side of the bed and even attempting to stand. One day I walked into her room and together we would uncover the devastation that had been laid by a critical illness. Over the course of the past few days, she had been medically stabilized, brought back from the brink of death. She had survived and no longer required medications to maintain her blood pressure and ensure life-sustaining oxygen flowed to her vital organs. She was now breathing on her own and no longer needed a breathing machine. Our unit is a deadly one. 17% of all admits, 1 in every 6, die. And the stats are worse if you require a breathing machine, 1 out of every 4. While it seemed likely she would survive, at least in the near term, her and her family were about to discover the aftermath of critical illness. She was fatigued and weak, barely able to lift up her arms or her legs. Her shoulders hurt. I helped her roll and sit up to the side of the bed, but she needed support. Any movement increased her shortness of breath. She was delirious and confused. She had not been hit by a car or had a surgery. She had not suffered a stroke or been burned. She was medically sick, her body responding poorly to an infection, and her lungs failing. After only days in the ICU, I did most of the lifting as I helped her stand up while she gave maximum effort. We did not stand for long. As I organized and untangled her jungle of lines that were everywhere around and within her, the family too looked tired and fatigued. They inquired when she would walk again and be able to eat and have a stronger voice. When will she go home, they asked, struggling to understand what had happened and what was next. Those who survive critical illness exhibit profound and long-lasting problems for years after they leave the hospital. Many will develop significant and debilitating weakness. They complain of fatigue, prolonged physical recovery, anxiety, depressive symptoms, and even post-traumatic stress disorder. Many do not return to work, and many have difficulty walking. Families suffer complicated grief despite their family member being alive. The physiology of critical illness, the treatment process, and the ICU environment are a devastating triad that leave no body system unharmed. Keeping dying patients alive is brutal. Often the required measures appear barbaric and torturous to the outsider. And for those that live, the statistics are staggering. Post-intensive care unit syndrome recognizes that the legacy of critical illness is profound and not limited to the patient. I witnessed the devastation firsthand, the side effects of sickness, medicine, and machines. I envisioned a better future, a vision to combine what was known about the horrific and lasting effects of critical illness, as well as the safety and feasibility of initiating physical therapy in the ICU. An idealistic dream that we could fix this, if only we started early enough, got people moving, woke them up, and kept them strong and getting stronger even while on life support. In April 2015, that vision became a reality as my team of 3 superhero PTs entered our 24-bed medical ICU. Not even I could have predicted our success. Patients now stand on ventilators and sit out of bed in chairs on continuous dialysis machines. 67% of all patients now receive PT in the medical ICU. On average, we initiate some type of therapy within 33 to 48 hours, even if the patient is on life support. Physical therapists are now an integral part of the ICU. Myself and my team are in a unique situation as physical therapists in critical care. We are afforded the opportunity to spend one-on-one time with patients and families without the risk of being urgently called away. We spend 30 to 90 minutes a day after day, sometimes for weeks on end, with the critically sick and near dying. Our impact is profound, sure, but the impact was not exactly as I predicted. Sometimes we opt for comfort over intensity, questions and a listening ear over more activity, gaining insight into patients' expectations and wishes. I sit with patients and witness the pain of realization as limitations are unwrapped and discovered. The gift of uninterrupted time illuminated a darkness within critical care and healthcare. What I have witnessed and what I have studied have given me more to ponder regarding critical care and medical decisions. For one, mere survival is not enough. We all want to live. It's an evolutionary instinct. The question, what are we willing to live through, now and in the future, is perhaps the most important one in a time of ever-improving medical technology. Our ability to save and extend life, our potentially narrow focus on reviving the vital organs, has far outpaced our ability to deal with the aftermath. So change begins with broadening our perspective beyond just the life-sustaining organs to the muscles that produce movement, the nerves that command those muscles and sense the environment, and the brain that gives us the gift of conscious perception and experience. We are keeping patients alive, but how can we help them live? Let us explicitly ask patients and families their hopes, desires, and expectations. Treating critical illness is not merely about warding off death. Many patients and families may be embarking on journeys with unrealistic or impossible expectations. Many patients will never rebound fully, and some will never go home. They will spend their remaining days and experience their death in long-term care hospitals. This potential reality should not be discovered blindly or unexpectedly. In order to ensure we do not continually create victims of critical care, an essential detailed conversation includes at least these 3 questions. What does ideal recovery mean and look like to you? What is important to you in regards to physical and mental abilities? If you survive, what is the bare minimum acceptable state for you? And what are you willing to endure for the possibility of the things you wish? So if we look at question 1, what does ideal recovery mean and look like to you? This is the idealistic vision and likely the expectation of the patient and family. It's what they are thinking and dreaming of. Where will you be and what will you be able to do? But we also must ask and consider, what if that is unlikely? What is important to you in regards to physical and mental abilities? What are your conditions of satisfaction? Talking, walking, eating, reading, sitting on your porch? If you survive, what is the bare minimum acceptable state for you? This is the most you're willing to put up with. Physically, mentally, symptoms, even your location. What if you're in a nursing home, have constant fatigue, can't eat, require care for others, have shortness of breath, are unable to walk? These are all things we must consider and talk about. And what if even that doesn't happen or is potentially impossible? What are you willing to endure for the possibility of the things that you wish? This is the foundational question and leads to the question that our palliative care colleagues always dive into, which is, what gives your life meaning? You would think or maybe assume that these questions are being routinely asked, but my sense is they are not. There is currently, across all disciplines and across all settings, a lack of training, time, expectation, incentive, and focus on such things. But if we are to change, if we are to get better, we must make time, train for, and engage in these remarkably difficult conversations. We must consider them from time point 0. What if the potential life-saving interventions we intend to be temporary, such as a breathing machine, become permanent? What if the side effects we assume to be transient, like weakness and confusion, instead endure? There is a human cost to critical care, and it's necessary to focus on the struggle suffered by survivors and their families. If we don't, why save the life at all? It won't be easy, but in order to guide patients and arrive at the best healthcare choices, we must commit to speaking directly and honestly. By understanding what gives a patient's life meaning and what they are willing to experience, to suffer, we may make clear what is an acceptable outcome and what is the best course of action for each person. For some, less intensive and more palliative measures. Less machines, less medicines, less hospitalizations. For others, a focus on getting home in any condition. For others, preservation of physical and mental abilities over life extension. And for some, anything and everything to exist. But to each, their own. Because if we don't inquire, for some, they may be sentenced to a fate they never imagined, a fate they never desired, a fate worse than death.